Analyses, Dr. Mayesha for a conversation on the human side of AMR.
To different models of 50 VLNs to be priced.
Oh, that's nice.
Dr. Shamas, Nour.
Try it again. Hello.
I don't know, you can speak.
Sorry, everyone, we're just getting the audio sorted.
I'll send you a piece.
I'm on.
There's no reason to this.
Let me walk to the mic.
How are you doing?
Fine. It's just, it's an adaptation.
Obviously, we're in the. And I have to. I don't, but. Well, I'll see you tomorrow. I'll see you tomorrow anyway. Oh, that's right. We've got the hot. I'm going to.
I'm sure we can project, but I don't want to. Oh, I think it's starting now.
Yeah.
Okay,
Yeah.
great. Sorry, and thank you for bearing with us. Well, Dr. Shamas, Nour, it's a real pleasure to have you here for what is a really important conversation and the first part of a two-parter on antimicrobial resistance. And in particular, we are sitting down to talk about your experience both personally and professionally when it comes to the lived reality of AMR. So your professional journey on AMR has been deeply influenced by your personal experience as a caregiver for your mother who survived an AMR infection. Tell us a little bit about your mother's battle with AMR and how that shaped your professional trajectory.
Yeah, thank you for having me and for having my mom's story. She's very excited to share her story always. She says hello. She's fine now, relatively. But so basically, I'm from Lebanon, and my experience in infectious diseases started a long time ago. Growing up in a very nice part of Beirut with access to everything that I could think of because I am relatively privileged. So at the time that in 2018 my mom got sick, she had to have emergency back surgery, and I was actually in the US at the time at a conference, an infectious disease conference, learning about all the exciting new research on resistant organisms. So she had her back surgery while I was away. A couple of months later, she tells me her back pain is getting worse, and then she started developing urinary tract infections. At the time, she wasn't diagnosed early enough because people thought she had a back problem. But then it turns out she had a kidney infection and the bacteremia, which is bacteria in the blood. She was septic. She started taking antibiotics that we had to pay for out of pocket, of course. She had to take IV antibiotics at home that we had to pay for, home health care. And then she started getting recurrent infections. That's when she started asking me questions that I had never thought of before, like, why is it that I am getting these recurrent infections? Is this a sexually transmitted disease? Why do I have to see an ID specialist, an infectious disease specialist? Because it's sort of stigmatizing. I don't want to have this on my profile, in my patient profile. So I learned a lot of things from her eyes as a patient, because earlier I used to think, right, this is just an extended spectrum, this is just an organism, it's not that big of a resistant organism, it's not a big deal. But then you think about, all right, this patient can't touch their family members. This patient can't, they have to take IV antibiotics. We don't have access to these antibiotics. So I used to carry these antibiotics with me from abroad to Lebanon because you can't buy them in Lebanon. Diagnostics. We're very lucky because we went to a good hospital that we can pay for, but most people don't have access to diagnostics. Sure. So that's been a really big part. And I just came from Turkey because I had to take my mom and my brother to Turkey because in Lebanon things are really bad. So we had to take the antibiotics with us just in case she has an infection there. And then now they're back to Lebanon, which is another issue, but yeah.
So, I mean, I'm listening to you speak, and first of all, I just want to say thank you for sharing your mother's story. And, I know that you are an advocate, a champion, a physician, and you're passionate about this, but I imagine it's not easy to talk about it because you had to live through that and support her, and none of us likes to see our loved ones suffering. So first of all, thank you for sharing your experience and really humanizing what might otherwise seem just a scientific or statistical problem, but in fact doesn't just affect the patients who are undergoing that experience, but their caregivers, their family members, and their communities. And through that experience, you were mobilized to act and to use your voice and your expertise. And so I want to talk to you a little bit about that. You've led AMS programs in various healthcare settings around the world. And one of the questions I wanted to ask you are, what are some of the most significant challenges that you've encountered when working in very diverse environments, and how can the international community better address those specific challenges in order to really move the ball forward on AMR?
Yeah, thank you. Actually, I'm very lucky because I did work in different environments, and I think the common denominator or not failure of stewardship programs, but difficulties, is that people think of stewardship as like its own new program. But stewardship is effectively using resources appropriately. So that's a patient safety thing. It's not a new program that's, we have to implement a new antimicrobial stewardship program. You need to find ways to embed stewardship into current processes. And that's what people have trouble with, as all of you in your work probably face. There's a little bit of ego when it comes to new programs. There's a little bit of ownership issues. And those are the kinds of things that stewardship leaders need to kind of break down so that you can implement proper stewardship. So finding your way into the hearts of the patient safety specialists and the surgeons and the leadership and logistics that buy the medications and make sure that they're available, or making sure that diagnostics are purchased rather than just thinking, let's just buy antibiotics, use them empirically, and instead invest in getting really good diagnostics. Yeah. So those are some of the things. And I think another big part is education. The US is another ball game, but in the most parts of the world, there's not really a lot of stewardship education, meaning there's not training on the undergraduate level. If you talk to most medical nurses, pharmacists, physicians, no one really knows what AMR is. No one really knows that infection control is their responsibility. You can't just say, okay, it's a nursing issue. And even how many stewardship trained people have you seen? There's not really a lot of stewardship focused training, specialization. And lastly, what I think is a really big problem, especially in the low middle income countries, is implementation science-based research. Yes, of course we care about new medications, but what we want to know is, from my perspective, is should I use the $500 that I have today on, let's say, switching IV to oral antibiotics, or should I use it on buying the most expensive new medication for these two patients? So what is the most interesting thing for me?
Yeah, no, and those are really important and complex considerations, and we're almost out of time, but I just want to end with one last question, which is, we're here on the eve of the AMR high-level meeting tomorrow, and the next segment will focus on AMR as well. What is it, from your lived experience of being an advocate and a caregiver, that you want policymakers to understand in terms of AMR survivorship?
I think first thing is to include AMR survivors in meetings and boardrooms, because sometimes what you think really is most needed isn't really, we don't have a lot of evidence sometimes, and you need to include patients with lived experiences. WHO, we worked on a document it's entitled The Meaningful Engagement of AMR Survivors, so please look at that document. The other thing is, in healthcare infrastructure, of course, it requires strengthening. You need to work on universal healthcare coverage in order to implement proper stewardship, but also finding ways to bridge the gap between policymakers that are outside of health that look at, for example, conflict, for example, making available proper roads for people to access healthcare. So these are, of course, yes, of course we need to work on AMR, but embedding AMR into other policies, AMR-sensitive interventions, I think, is something we really care about.
Yeah, thank you. I appreciate that last point and that kind of whole ecosystem approach, if you will. Well, those are some great and practicable recommendations, and I appreciate them very much, not just from your perspective, but because I think they will definitely inform and shape the next segment that we're about to have as we dig in deeper on AMR. But Nour, thank you so much for joining us, for sharing your and your mother's story, and for taking the time to raise awareness and educate everybody. Thank you.
Thank you.
Please welcome Dr. Monica Balasegram, Executive Director of the Global Antibiotic R&D Partnership. Dr. Sumi